We can discuss the viable options in CRT non-responders or the role for programmed ventricular stimulation. Which would you prefer? If you go for CRT?
Yeah, the CRTs. There's not that much to say about risk stratification. Yeah. You can summarize it in...
Well, I would say I would need probably more than 5 minutes to address the topic of CRT non-responder, which is, I have to say, first, the definition of a non-responder is extremely vague. I mean, if you ask the 7 of us, I mean, you get probably 10 answers, 10 different answers, I'm sure about that. So I think that, again, if we now think that non-responder is symptomatic or remodeling, because proportion diverge significantly if you take one or the other one. But in general, we acknowledge the fact that CRT may not fit all the patients. And I hear now, over time, we have learned more and more that we may have some inability, and this is what I would describe as our inability to use in the right patients the right delivery of CRT. In other words, if you have a right band branch block patient, because this is now where the situation is going, and we're using CRT, which is mostly resynchronizing the left part of a heart and leaving the right side of the heart as a standalone, this is a typical failure mechanism, because you're not able to deliver the resynchronization on the right side of the heart and just putting on the left side. For patients with diffuse interventricular conduction disturbances, I think it's another very, very large group of patients, and they have really no idea. I would be very curious where Pierre, because he has also done a lot of very good work in trying to mechanistically understanding what is wrong in these patients with different kind of mapping techniques. And I think there is really a major need from the electrophysiology community to dive more into the substrate, so define what is wrong electrically before we look into the mechanical part. There is a group of patients who certainly has valve dysfunction. I mean, the mitral valve dysfunction is a major failure mechanism, so becoming symptomatic, so non-responder. And then it's another very large group of patients who still retain scar, and where really the scar is a major mechanical problem. And whether stem cells or biological therapies, whatever you like, they may be a sort of hybrid or combination on top of CRT, that might be a solution. I don't know, because there are very, very few reports about that. So I think it is a really huge universum. And again, we cannot make one single non-responder patients making equal to the other one. So again, there are multiple reasons why you may fail or you would not become responsive to CRT. I don't know what Pierre you have.
Yeah, I mean, I think you've covered it, summarised it beautifully in such a short time. I think the challenge, we can talk about therapies that are going to occur in the next 15 or 20 years, or what can we do realistically within the next 5 years. And I think a fundamental principle also is the fact how much myocardium is viable that can be recruited to improve the cardiac output. And we've tried tentatively with multi-site pacing, and I think potentially there are lead technologies which are emerging, which may allow us to access multiple sites in the coronary venous system, where you could use collaterals between veins to feed a very fine pacing wire and pace at 2 or 3 sites simultaneously. And I think that's a solution that's very much on the horizon, and endocardial pacing is also another option which does cause remarkable improvements in hemodynamics, but where we have the risk of transeptal and placing a lead in the LV. But the leadless technologies are becoming available, and it may well be in the very near future we put a small electrode endocardially in the LV delivered, and we can pace and optimize hemodynamics very simply without the complexity of accessing the venous system.
I mean, there's a difference between a non-responder and a failure of CRT, isn't there? In that, I think we're increasingly knowing that what we think is a non-responder may not be a non-responder. Yes. We've just arrested the progression of their symptoms in a heart failure. Yeah. Whereas the patient where you haven't been able to deliver the lead to a satisfactory position may be handled in a completely different way, where transeptal approach or epicardial approach may be a big avenue for the future.
When I listen to all this discussion, always I think we overestimate the problem of non-response. I think in CRT, this 60–70% response rate is marvelous. It's really breakthrough in treatment. We have mortality data, we have data about a reduction of hospitalization, and of course we are dealing with disease that is like end stage of cardiac disease. So we cannot expect 100% response rate, and I fully agree that we have to explore all these new avenues, but we also should emphasize that we achieved a lot, because CRT really changed the life of many patients, and we don't need to be so shy, and we should emphasize more the advantages and the benefits we get from the treatment.
I absolutely agree with you, Josef. CRT was one of the few really game-changing techniques and technologies invented by Angelo mainly, and driven forward in the early days. And it's really amazing for the individual patient that you have, and for study data that you look at, that you have a therapy. Once it is in place, it is with very, very few side effects, or with no side effects as compared to drugs. And it delivers an improvement of quality of life. It prolongs life. So it is for heart failure patients a beauty. However, 30% of the patients do not get this benefit. I agree with you that non-responder or failure to therapy is a little bit too tough, but they do not gain the benefit. And I personally believe that we have to go deeper into the question where to place which individual patient. So, as in atrial fibrillation, catheter ablation, where we move towards personalized treatment, individualized substrate analysis and therapy application, I think there is still some space in the CRT segment as well to give the beauty of CRT, this huge benefit, to more patients with heart failure.
We had a very interesting experience 5 years ago where we were trying to recruit patients for a surgical lead placement study. So we were recruiting patients who were non-responders, and part of that recruitment process was that we switched off the LV lead to prove that they were non-responder, and almost all of them got a deterioration in symptoms, even though they hadn't improved with CRT. We couldn't recruit for the study.
Yeah, amazing and important by the same time.
Yeah.
And that sheds a different light on the problem.
Yeah.